I think we'll start in 30 seconds. Request everyone to mute their microphones and okay, we're live. Good evening, everyone. Welcome to another chapter in this series of masterclasses brought to you by IASO Academic Council. I welcome you to today's webinar. I invite our convener of the Academic Council, Dr. T. Subrameshwar Rao, to kindly deliver the welcome address for today and open the session. Sir.
It has been close to 2 years now. This is the second segment of the master classes, which have been very well received, both live and later on also. Truly appreciate the IASO leadership, specifically Dr. Rajendra Toprani, President, and Dr. Chandramohan, Secretary, for driving this for the past 2 years. I also appreciate the leadership for giving us a chance to run this. We are actually called the Academic Council of the IASO, which runs this every fortnight. Today we have 2 examinees. Naveen Verma is from GCRI Ahmedabad. Abhijit Mondal is from AIMS Rishikesh. Appreciate them because they volunteered as examinees. We have 2 examiners. Dr. Shivendra Singh is a friend for a very long time. He is a senior consultant and head of gastrointestinal oncosurgery and liver transplantation at the prestigious Rajiv Gandhi Cancer Institute. He has more than 28 years of experience in the department of GI oncology. He has worked in various places, and he's an active member of various international liver societies and a reputed faculty speaker in all these. He has more than 100 publications to his credit and has made more than 150 presentations in national and international conferences. The other faculty is Dr. Manish Bhandari. He's an MS and MCH with a specific interest in GI and Papillary oncology. He's a professor of GI and HBB surgery in the Department of Surgical Oncology. Once again, a very prestigious institute, the Tata Memorial Hospital and Center, Mumbai. He has close to 50 scientific publications, authored more than 12 book chapters in various books on GI oncology. There were more than 50 invited lectures as a faculty in national and international meetings. Both of them are very eminent in terms of their work in GI oncology, and they are very, very passionate teachers. And that is the reason why they are here today to run this masterclass. Dr. Shivendra Singh will moderate this session. Manish is, I think, just joining. Moderate this session. Both of them will be examiners. And Manish Bhandari will be delivering an expert talk after the masterclass. Thank you very much.
Thank you, sir. A few instructions for the session to our examinees. We request you to give to-the-point answers. No candidate is ever expected to know everything. So just if you don't know something, just mention it, and it saves the flow of this webinar. Our examiners do have the habit of giving hints. So it's up to you to make that habit of reading the face and the body language of the examiners. For our examiners and the moderator, in interest of online viewers who are live right now, as well as people who are viewing this later on YouTube, we request you to give the expected answers to the questions that are incorrectly answered by the students or have been that remain unanswered. For the participants who are live today, both here on Zoom as well as on YouTube, the senior ISO members, we thank you for logging in, and we value your inputs that you put in the chat box. We welcome you to do so. The residents, it's a unique opportunity to clear all your doubts regarding this subject in the next 2 hours. That's the main advantage of attending it live. So please make full use of it. The first session would be the clinical mock case discussion, which would be given 60 minutes. I'll be reminding both the examiner and the moderator at 45 minutes and at 60 minutes via chat messages. So I request the moderator and the examiner to be on the lookout on the chat that pops up on the screen. I now invite Dr. Shivendra Singh and Dr. Manish Bhandari, along with Dr. Avjit and Dr. Naveen, to participate in the first part of the evening. Over to you, sir.
Good evening. I'll share my. Good evening, everyone. I think with Avjit and Naveen, we should start with the cases. The first case that I am presenting is a 27-year-old female who presented with pain in epigastrium for 2 months, dull aching with radiation to back, not associated with any vomiting or any episode of severe pain in abdomen, vomiting, hematemesis, any weight loss, loss of appetite, of any abdomen. Hello. On per abdominal examination, H's abdomen was soft, no lump was palpable, no other positive findings. Ultrasound abdomen was done outside. This showed rest, everything was normal except there was a cystic lesion in distal of pancreas. So Manish has joined, or Avjit, how you will proceed with this? Only pain in epigastrium and ultrasound showing cystic lesion. No other positive findings either on general examination or abdominal examination. Anything you want specifically on this ultrasound? Though it has described only cystic lesion. Anything extra you want in history?
In history, sir, I shall also inquire about any history of any jaundice is there or not.
No jaundice.
No, I mean, just for the sake of, hi sir, this is Manish here.
Yeah, Manish.
My question.
Yeah, Manish. Manish, are you able to hear?
Hello, am I audible?
Yeah, now you are.
Yeah, my question to him is, why would you need a history of jaundice for a lesion in tail of pancreas?
Sir, the history of jaundice is not that much relevant because for a tail of pancreas lesion, because usually it won't give rise to, but if there is any, if it's a malignant lesion, then due to lymph nodal involvement, it can give rise to a history of jaundice.
But Avjit, it could be whether a stone might have caused jaundice as well as gallstone pancreatitis, and now there is a pseudocyst in the tail of the pancreas.
Yes, sir, that's a possibility of pseudocyst of pancreas, but as we saw in the
any severe pain, that is the only.
Yes, sir, that's the only negative point against the pseudocyst.
Okay. Okay.
Hello, Naveen. Anything extra that you want? So how will you proceed, Naveen? No further.
Sir, relating to the age, 27-year-old female with non-specific signs and symptoms. So, and finding of a cystic lesion on USG. So first we'll proceed with MRI or MRCP of abdomen, sir.
Why not CT scan?
Sir, on the basis of the institute protocol, we will go with the CT scan also. So CT or MRI. But for cystic lesion and for definition, MRCP with MRI is best. So we'll go for MRCP or MRI.
An MRI, you like to have a plain MRI or use a contrast or
Contrast, sir. Contrast. MRI.
any specific protocol that you like to use, or it should be only a contrast that is sufficient?
The contrast, sir.
Avjit?
So I would like to go for a CT, contrast enhanced CT with pancreatic protocol for this patient, sir.
Okay. Manish, what is your take or anything that you want to add?
Yeah, both is fine actually. MRI and CT scan, both what they are saying. But the only problem is the knowledge of awareness of reading the MRI for surgeons. So are you guys comfortable in reading MRI scans, or would you always need some help from the radiologist, especially when you evaluate these tricky lesions?
We need help for MRI, sir.
Any on
Sorry?
Sir, yes, sir. We need some help from for MRI reading.
MRI, exactly. So both are options, either contrast enhanced MRI, but mainly the MRI is, I would say, useful for follow-up when you are keeping the patients on follow-up. That time, it's the advantage is that you reduce the radiation exposure, plus it is feasible to do it frequently. That way, the follow-up better is MRI. And sometimes you also need both CT and MRI as a dual imaging to confirm the diagnosis. If I may ask, what is the advantage of CT scan over MRI, and what is the advantage of MRI over CT scan for evaluating these type of cystic lesions?
So with CT scan, we can also, because of its high resolution, we can also gain a pretty clear idea about the location and its relation with the surrounding structures as well as the major blood vessels. And for also determining any specific features, like which is often seen in these lesions like calcifications.
Correct.
And sir, with MRI, we have seen like consistency of the cyst and the solid and the cystic part of the cyst.
Okay. Any other important information which MRI gives better than the CT scan?
communication with the pancreatic duct, you might be able to better appreciate on the MRCP.
Yeah, exactly. As sir said, yes, the ductal communication is also something which you need to know at times in a cyst when the diagnosis is unclear.
Other important thing, if you are comparing with the pseudocyst, in the MRI gives a good resolution to identify debris. You might assist debris in the dependent position. You'll find an MRCP debris which is not very well appreciated on CT scan. So that might help in differentiating between unilocular cyst or your pseudocyst. So this was the MRCP finding. Patient came with this report only, no films were available. So this was cystic lesion in tail of pancreas, 4.3 by 4.3 centimeter with eccentric nodule with thin internal septum. No solid component, no debris. There was suspicion, they reported as communication main pancreatic duct, which was around 2 millimeters diameter. So how will you interpret this finding? Though we don't have the images for this MRCP. Sorry for that, because this patient didn't have the films.
So as the lesion is communicating with the main pancreatic duct, so it goes more, and the main pancreatic diameter is less than 5 mm. So it goes more in favor of branch duct Ipmn.
Naveen, would you agree?
Yes, sir. Same, sir. Same.
But communication might be there with the pseudocyst also.
Yes.
Anything which will find that it is not seen Because there is an eccentric nodule with some septum they have reported.
Yes.
Sir, the eccentric nodule and the septum point towards the mucinous cyst, but the lesion was communicating with the MPD. But mucinous cystic lesion was not communicating with that MPD, sir. Main pancreatic.
Manish, anything that you want to add? Or Manish, are you able to hear?
Yes, there was some issue. I just joined from a different device. Yes.
So MRCP showed this finding. The problem is MRCP films are not available.
Okay.
Okay.
And I also heard someone saying that this could be a branch duct IPMN.
Yeah, I think Abjit was.
Ajib. Right.
So
What would you consider this as your diagnosis with this investigation, or would you like to do any other further imaging or investigation? What the thought process is right. There is cyst and there is duct communication, and the ductal dilatation, since it's not very big or more than a centimeter, then yes, it is likely to be a branch duct and unlikely to be a main duct. But this is good enough for you, or would you, I can directly maybe ask you whether you would also order an EUS test to confirm this, or you are happy with MRI test and go ahead with whatever plan that you want to make.
So I'd like to go for an endoscopic ultrasound in this patient, sir. Endoscopic ultrasound will further elaborate on the features which will be better seen on EUS, like septation, any solid component if it is there, and we can also obtain a cyst fluid for analysis and obtain a levels like tumor marker levels and amylase levels also from that.
Okay. Now, that is fine, but the only problem is, yes, are you aware of the guidelines, various guidelines, which indicate whether EUS test has to be done or not to be done in what particular situations? Are you aware of any guidelines for cystic neoplasms?
Yes. So the Sendai guidelines and few FOCA guidelines.
Sendai and later updated FOCA. And apart from that, there are a couple of more guidelines also, which indicate EUS, but the best one I would say is the European guidelines, which is the recent one. Can you tell us that what exactly it states, the role of EUS in which particular cysts? Because finally you have to also look at it as an invasive investigation when you are offering an EUS. It's an endoscopic procedure. So what additional information that you are going to obtain and how it is going to change your management, both are important things when you order this kind of an investigation. So what impact EUS is going to make in this particular case as to change in your management? That is what I'm asking.
Sir, if it is a branch duct mucinous cyst, branch duct in IPMN, at this size, we have to go for US to confirm, because the lesion less than 3 centimeter in branch duct US, branch duct IPMN, we can go for a surveillance also, sir, because of the less than 20% chances of malignancy in branch duct IPMN.
Okay. And more than 3 centimeters or 4 centimeters, that means what you are likely to require?
So then we just require the US.
And how EUS is going to change? That's what I'm asking you.
And also remember the patient is 28-year-old female. 28 or I think a very young female. Branch duct.
Yes, it's not a very common age also, but finally the MRI is suggesting that it is likely and branch duct IPMN.
Sir, if the cytology is positive for malignancy or something else, then we can go for the surgery.
And if it is negative, what are you going to do? That's my question. Is my question.
If it is negative, then we'll further process for CEA and all other things.
Okay,
sir.
I'm saying everything is negative. Your EUS findings are correlating with MRCP. There is some communication with the duct, but there is no MPD dilatation. Likely, branch duct Ipmn is the diagnosis on EUS also. But there are no other features, no other tumor marker elevation, etc. that you are finding. Amylase is likely to be raised because there is a ductal communication.
Then we can go for surveillance, sir, at this age.
But you yourself said that less than 3 centimeters is best for surveillance.
Yes, but again, sir, again, if all the other findings are negative, then we can go for surveillance. If
Yuvendra sir, would you like to add something to tell them? I mean, I'm trying to make a point, but
with young patient with 28, how long you going to give a surveillance? 4.8 is more than 4 centimeter size, and young female with ductal communication. I think treatment is going to remain the same. The treatment is not going to.
Exactly. So that is what the European guidelines in 2018 says, because the Sendai and the Fukuoka guidelines tried to say more than 5 millimeters rate of growth over a period of some 1 year or 2 year, or some duct dilatation size criteria, etc. But the European says very simple: if your management is going to change, only then do an EUS, or if you are in a dilemma, then only do an EUS. Here, CP and MRI has given you enough information for you to go ahead with surgery. There is no option of surveillance for cysts which are more than 4 centimeters when they are branch duct, and especially when the patient is young female. Had this been a 70, 75-year-old female, the story would be different. There you may say, yes, there is a possibility, but how long you are going to keep her under surveillance, and the risk of malignancy will increase over a period of time. That's how judiciously we need to use EUS. There is no harm in doing EUS, because if you go by the other guidelines, you may be right that yes, just a double check that we are going to do, and then still going to go ahead with the same treatment. But when you want to avoid something as an investigation which is over investigating, then you should see whether the management is going to be changed by that investigation. That's what is the theory. Okay.
So we'll proceed. So no role of any PET. USA we have discussed. Do you like to do it because we don't have films? You like to do a CT scan prior to surgical planning? And what are you planning for as a treatment now?
Before planning for surgery, we need to go for CCT abdomen pelvis, and look for the vascular communication or vascular abutment, and then we'll go for the distal pancreatitis.
Abhijit, you agree with this?
Yes, sir. Same answer.
So patient underwent a CT scan, which defined that. I'll show the films. These are the films you can see. Abhijit, you would like to comment on this?
Sir, here in these films, we can see the cyst is very clearly delineated, and the periphery, the wall of the cyst is taking up the contrast, it's enhancing, and it appears to be in communication with the pancreatic duct.
Where you are, I don't think anywhere. Are you able to see any communication with pancreatic duct in this scan? I don't think CT
It's
scan.
not very clear, sir, but
Any?
no, sir, it's not clear. Means any communication with the pancreatic duct, sir.
There is mild abutment with that left renal vein.
Left renal vein.
Yeah, that's just bulging, between or pushing, but there is no as such.
Involvement.
So would you like to change your diagnosis with this, or because the communication on CT scan, it is not appreciable?
So to determine the communication,
MRC.
I repeat, MRCP would be better if we actually need to find out the communication. CT with a 2 mm dilated duct, with MPD, it's not very prominently visible on
Same
CT.
issue, how it is going to change your management?
No, see, in either case, management won't change, sir. We will go ahead with the surgery.
Manish, you would like to add?
Yeah, I mean, when you read any imaging, it's just a general point, like knowing that there is some cyst communication with the duct, you try to say that there is some communication seen, but actually in the images provided, you can't really make out a pancreatic duct. Unless you see that, you should not make any comment on that. Rather than that, you should focus on the morphology of the lesion, how it is appearing, where exactly in the pancreas it is located, its relations to the splenic artery and splenic vein. They become most important when you are evaluating this lesion. And then, yes, as Naveen said, that it is indenting on the renal vein. It appears completely well circumscribed. All that is the idea that you need to, and there are no liver lesions, there is no regional lymph nodes that are seen in the scans provided. So that you should say in this particular thing. And also this looks like a posteriorly located lesion rather than an anteriorly located close to the stomach. And once you say that, yes, we will go ahead with plan of surgery, then you should also mention what exactly is going to be a surgical plan. Maybe that's your next question, sir, to them.
No.
Is it not? What surgery are you going to plan?
Naveen, what are you planning?
So
Naveen?
yes, sir. Sir, we'll go ahead with distal pancreatectomy. And there is no communication with the splenic vein or the renal vein, so just distal pancreatectomy, sir.
The distal pancreatectomy is spleen preserving, splenic vessel preserving.
Spleen preserving.
But not preserving vessels.
The vessels seem to be closed. It's a
Yes,
posteriorly located bulging
yes.
lesion. The vein is likely to be stretched over this lesion. And when you dissect splenic vein from such type of tense cyst, there is likelihood that you may rupture the cyst. So is it going to be safe to do a spleen preserving? Based on, because all this starts from planning, starts from your radiology before going in for surgery. If you know all these things, only then you are going to make the correct steps inside the OT. In OT, if you decide to do some assessment, etc., and then see, you are likely to end up in rupturing the cyst also. That is also something that you need to be keeping in your mind and plan accordingly. That's why sir is rightly asking you, if you want to do spleen preservation, will it be splenic vessel preserving also or splenic vessel removing? And what is the real advantage of spleen preservation versus no spleen preservation for distal pancreatectomies? Is there any proven advantage of spleen preservation?
So at this young age, there is advantage of spleen preservation. 22 years of old female.
What is the advantage? Is it proven in studies, data?
It's not that proven, but
in fact, there is data that it does not add anything. Spleen preservation becomes technically demanding surgery, and it does not add much if the patients are vaccinated well. The incidences of OPSI, etc., which was thought to be there before, is no longer existent in today's time and era. So it doesn't add much, the spleen preservation. So it is possible. When it is easily possible, you can do it. But when it is tough, then don't even think about doing a spleen preservation because it's not going to add anything. Okay.
Yes.
And Avjit will like to do laparoscopic, open, robotic. What is your?
So I'd love to. So I'd like to go for a open surgery in this case, sir.
Any reason?
Because of the large cyst and its very close approximation with the splenic vessels.
So Manish, you want to add?
Yeah, if you're going to go for a open surgery, that's fine, but your justification also needs to be in that line. So if you say that the cyst is large and it's located posteriorly, laparoscopic instrumentation is likely to rupture the cyst from behind when it is lifted, that would be taken well. But if you say splenic vessels are closed, you are not going to take the splenic vessels at the cyst. There is enough space available proximal to the cyst where you will take splenic artery and vein. Correct, isn't it?
Yes, sir.
So that is another reason. But having said that, if you have good technical skills available to not touch cyst and do the dissection around and safely do it from laparoscopy or robotic approach, that is possible. Otherwise, you can safely say that also, that I don't want to rupture the cyst because that is going to impact the management later or the overall prognosis and future course of this patient. So I would prefer open surgery. Both options are fine. You need to speak up for or against them. That is what you should look at. Okay.
Yes, thank you, sir.
So patient, this was another. So I think we have discussed all these things. Any other measure? Patient underwent robotic distal pancreatectomy. And again, the same Manish that pointed because it was very adherent to the splenic vessels and stress. So no splenic vessel preservation was planned. State powered robotic distal pancreatectomy with splenectomy was done. And these are the operative pictures. Anything that Avjit, what stapler cartridge that you like to use for transecting the pancreas?
So I'd like to use a Endo-GI vascular stapler, sir, 60 mm.
For vessels or for pancreas?
So I'm not sure, sir.
Okay. So Manish, what is your preference?
It depends on the thickness of the pancreas. Sometimes we tailor it based on that. If it's not very thick one to staple, then it's, I mean to say, a very thin side or narrow side, then yes, wide reload is preferred, or at times in thick sizes, we use blue cartridge also. And in very thick ones, we prefer to transect and suture it off rather than a stapler because the chances of fracturing become high in those cases.
So this is the final histology, which shows it is a well-circularized cystic lesion with columnar epithelium with intracellular mucin. A stoma was resembling ovarian stoma. No evidence of any invasive components. Lymph nodes were all negative. The stoma was positive for PR and Desmond, while the epithelial component shows MUC5AC positivity. It was a low-grade mucinous tumor and not an Ipmn. So how will differentiate histology on Ipmn versus mucinous tumor? What is the finding that? Single most important finding that?
The single most important finding will be the presence of the ovarian stroma, which is essential for diagnosing a mucinous cystic neoplasm.
Okay. So anything, Manish, you want to add or proceed to next case?
Yeah, I think histologically, yes, ovarian stroma, yes, mucinous, plus the age also was not somehow fitting into a branch duct IPMN, which happens in much older age. MCNs are generally middle-aged and females again. And also the IHCs, which shows MUC5AC positivity, that is slightly in favor of an IPMN. Because MUC5AC is a pan IPMN marker, which is most commonly seen, but that's only focally positive.
Focal positivity.
So that way, yes, you need to be aware of these markers, and of course, the pathologist will give you the final call, but clinically also you need to correlate because it looked like a nice mucinous lesion on CT scan imaging. That's how it has turned also out in the final pathology.
So we'll move to the next case. Any further treatment? Anything further follow-up?
So we'll keep the patient on follow-up with annual annual CT scan or any imaging, CT or MRI imaging annually?
Okay.
Or
Any specific protocol guidelines which mentions?
And how long are you going to keep which protocol, and how long you are going to follow them up? And you said CT and MRI. That I would say is a wrong answer in exam, because you want to avoid CT scans. That's the advantage of MRI.
MRI.
You are keeping patients under follow-up for observation. Here you have treated a patient by removing the entire cyst, and you are still wanting to do repeated CT scans. Is not going to be taken well. Okay. So
Yes.
how long you want to follow? You should read that up. Okay.
Yes.
And sir, there is also a comment in the chat box about commenting on spleen preservation while resecting the splenic vessels. That's the Warshaw technique, as they call it.
Yeah.
So would you like to comment, Abjit, on spleen preservation with resection of the splenic vessels? Is that possible, and how does it work? Or what's the Warshaw technique?
I'm sorry, sir, but I can't elaborate it nicely. I don't know about it much.
Okay. And we lost the other examinee, is it?
Yeah, he said he's joining back. Just wait for him.
Okay.
With Warshaw technique, you can preserve the short gastrics. If the left gastrocolic is patent, you can preserve it. And that is the important thing that. But still the splenic ischemia, infarcts can occur, and the infections, complications can occur. So otherwise, the best option is to splenic vessel preserving if possible. If you are in case it is not possible, then the second option is the Warshaw that you can fall if you want to preserve the spleen. Otherwise, Manish told there is not much difference. You can take out the spleen also.
Yeah, thank you, sir.
So we will move to the second case. Again, a 22-year-old female, pain in abdomen, again lacking pain, epigastrium, and no jaundice, no loss of type, no other positive findings. And ultrasound showed hyperechoic lesion in head of the pancreas, closely abutting the portal vein and assembly. So, Avjit, how will you proceed? These are the typical cystic tumors. Not much of symptoms are there. They are picked up on imaging for vague symptoms.
Sir, as there has been, I'd like to find out about any history of any acute pain abdomen radiating to back, because it was not specified. So if it is there, then it will, based on the history, it will point towards a pancreatic pseudocyst.
There is no severe acute any symptoms history of acute pancreatitis or trauma in the past. So any comment on hyperechoic lesion? Whether this gives some hint that what it could be, whether purely cystic, how it will appear. So how will investigate further? Just tell.
Sir, next I will go ahead with a contrast enhanced CT scan with pancreatic protocol
Okay.
to further evaluate the lesion.
So patient showed this findings. There is a large mass 6 by 7 centimeter with around 180-degree contact with assembly. Lesion was abutting duodenum with effaced names. C99 was 10. These are the imaging findings that you can see. Will you describe? Naveen, are you able to see? Or
yes, sir. Yes, sir. Sorry, sir. Oh, there is interruption with the net. Sir.
By that time, Avjit will comment on the CT scan findings.
Yes, sir.
Sir, we can see in the CT images, we can see a well-defined mass lesion. It's appears to be involving the distal pancreas.
Distal pancreas?
Sorry, sir.
Sir, it
I
mostly
mean, by
involves the head of the pancreas.
Head of the pancreas, it's involving. And there are some areas of some dark areas which appears to be a necrotic material or necrotic areas is there within the cyst. It's also compressing the duodenum, which can be visualized. It's very duodenum is effaced by the lesion, as well as in the posteriorly we can see it's also compressing the blood vessels. Most likely it's a SMV. It's abetting. And there are no other further lesions noted elsewhere in all the other rest of the imaging, sir. In the liver or in the stomach or in the bowel wall, sir.
So, Naveen, what is your opinion? What is your diagnosis based on this CT scan?
You have lost him again.
Okay. So how will you proceed, Abhijit? This was the findings. So what is your diagnosis on CT scan? And how you will proceed?
Sir, sir, in this, based on the CT scan, it's a head of the pancreas lesion. So we need to evaluate it.
What is the commonest diagnosis that you will differential diagnosis that you will keep in a 22-year-old female with this mass?
So, commonest will be pseudocyst pancreas, sir.
But it appears to be pseudocyst picture.
No, sir, it doesn't appear to be one on imaging. Simple cystic neoplasia, but
is it cystic completely? How would you describe this lesion?
So it's a solid lesion. So most likely it can be a solid pseudopapillary lesion of the pancreas.
Absolutely. You're
No.
How it is looking. It's not looking purely cystic. It is mixed, solid and cystic.
Solid cystic.
Less of cystic. Mainly you see solid component only, and a large lesion, and the age of the patient. That's what sir was trying to tell you. Means that it is a solid pseudopapillary epithelial neoplasm. Do you want to do a biopsy to confirm it?
Yes, sir. I would like to go for a biopsy. But sir, it won't change my management in this, because in either ways we'll have to resect it.
Okay.
As it's compressing the duodenum.
Okay, good.
So
then you don't need a biopsy. That's what
we don't need a biopsy, sir, in this.
Correct.
We'll go ahead with after optimization of the patient, we will go ahead with the surgery in this patient.
Naveen, so no further.
Am I audible, sir?
Yeah, now Naveen, you are audible.
Yes, sir.
We have discussed no further investigations or biopsy is needed.
Yes, sir.
It is a very clear-cut solid pseudopapillary tumor.
Yes, sir.
So what will be the plan for this, Naveen?
Sir, as the lesion is large enough for processing, then we go ahead for surgery, sir.
No, sir is asking you about need of any other test. Okay, biopsy we discussed, we don't need it. But do you need a PET scan? Is pseudopapillary tumor benign?
Sir, pseudopapillary, there are
malignant.
Sir, there are chances of malignancy. There are moderate to high chances of malignancy. So we can, sir, at this large size, we can go for the PET CT scan.
Is CCT triphasic not sensitive enough to pick up Where is the common metastasis, if at all it happens in a spen?
Sir, mostly it can go to lungs. So CCT chest.
No, most common is
Most
liver.
common state.
Most common is liver because they are large, they often grow large. They are in contact with portal vein and smaller tributaries of portal vein. That's where the small tumor cells can slip, or they can also form a tumor thrombus within portal vein, which goes to liver, and they are likely to develop liver mets. That's the most often site of metastasis. Which triphasic CT scan is a good enough sensitive investigation. And anyways, it's a low grade tumor. Even if it is malignant, it's low grade. So the activity that you see on a PET is less. That was a leading kind of a question, which you need to answer that, yes, we don't need anything else if you have a good quality triphasic CT scan of thorax, abdomen, and pelvis. Is it not?
Yes.
Okay.
So the management to plan is surgery. Any special precaution in this case you'll plan because of location and anything? Naveen?
Sir, there is abutment of SMV, so we have to be careful about that. So, and
So you
sir,
should be prepared for any resection or any bleed from major vessels. You should be prepared for those things, and you have to be.
yes, sir, and any kind of reconstruction is if required.
So she underwent Whipples. There was well circumcised lesion, and the abutment was continuing till the first jejunal vein, and few soft lymph nodes were there. This is the picture you can see. So it was only abutting, no involvement was there. Most of the time, these spans are only pushing, but rarely infiltrating. So this was the histology, and so any treatments, it is T3 solid pseudo-papillary tumor. Any further treatment plan, Naveen, you would like to? Anything is required or?
Sir, it's a low-grade malignancy, so we just follow up, and there is no lymph nodes also, so we just follow our surveillance.
No further treatment is required. Only
no further.
And,
yes.
and since you said there are no lymph nodes, so surveillance. If there are lymph nodes, then what?
Sir, then we'll go for adjuvant chemotherapy. No, sorry.
See, that's how.
Since it's a low grade malignancy,
to be conservative in your words when you use. Also, you should not give these leading points to the examiners also to ask you.
Yes.
You could have easily said observation alone.
Observation. Yes, sir. Observation.
Said nodes, then I had to ask you, but there is no adjuvant therapy even for metastatic spens. Even if there are liver mets and you have done a Whipple or done an R0 resection, there is no chemotherapy adjuvant per se. You can have some liver directed therapy for an unresectable metastasis in the liver when you remove the primary. But there is no adjuvant chemotherapy per se, unless it's a very palliative situation. There are some reports that you can give palliative chemotherapy to just limit the symptoms, but that is also not a very high level evidence. There is no adjuvant therapy for most of these cystic neoplasms unless it is an invasive Ipmn, where there is an adenocarcinoma in the background of Ipmn. Only then comes chemotherapy, but otherwise none of these tumors require any kind of adjuvant therapy.
Yes.
So should we proceed with third case? The third case is a 52-year-old diabetic female. Again, the same, only dull aching pain in upper abdomen for 2 months. No other positive history, no evidence of any pancreatitis or any pain in the past. And ultrasound showed the pancreatic had a space occupying lesion with calcification. That is the only positive thing. So Naveen, how you will proceed? Again, the same CT scan.
Yes, sir.
Yeah. So CT scan was done. Pancreas was replaced with predominantly cystic mass with foci of calcification. CA19-9 was 366. These are the findings. Abhijit will like to read the scan
Sir, that cystic lesion completely occupying the pancreas, and there is atrophy of the main parenchyma. Hello.
Calcification in the head, are you noticing?
Yes, sir. Yes, sir. There is calcification.
In anything solid component, anywhere you are seeing in the cyst? You can see on this area, this is a solid.
There is some solid component in the head, sir.
And this calcification is there. Could it be chronic pancreatitis with dilated duct, or it is a malignancy? Avjit, will like to comment on this?
Sir, the pattern of calcification, it points towards a malignancy.
What pattern of
in communication, it's communication with the main pancreatic duct, it seems.
Where is the communication and where is the duct? I feel this is all, it is the duct only.
It is the duct, yes.
Duct.
Duct is massively dilated and atrophy the pancreas, the pancreatic parenchyma.
So only thing is, there is some solid component massively dilated pancreatic duct. This calcification in head could be previous, it is unrelated, but this solid component is there and massively dilated. So my diagnosis will be a main duct Ipmn. Manish?
Yes, sir.
Any your comments
Yes,
on this?
Yes, sir. Just to tell them that whenever you see this much amount of duct dilatation, it has to be Ipmn. There is nothing else which can present with such a massive duct dilatation. In chronic pancreatitis also, you may get some ductal dilatation, but it is often focal or stricturing because the duct also gets strictured at multiple points, and you don't get such a uniform or fusiform duct dilatation in CP. Here you can clearly see solid mass, and yes, the calcification at times can be confusing because that is mainly associated with CP, chronic pancreatitis. But such amount of dilatation of ducts, you must always think about an Ipmn.
So we made a diagnosis of Ipmn. Any further workup? Again, the same questions. US would like to do anything biopsy, FNAC. Now I think we have discussed. Naveen?
Nothing, sir.
Nothing?
Nothing.
Just also you not like to do?
Sir, is it the main pancreatic main duct Ipmn? So there are more chances of some underlying adenocarcinoma also.
It could be associated with some invasive component.
Some invasive.
Can do CT chest,
Yes.
especially low dose. Otherwise,
Yes,
no PET scan or is required for these things.
Yes.
So what will be your plan, Avjit?
I'll plan the patient for pancreas Whipple's procedure, but intraoperatively, we will, if possible, we will also do a pancreatoscopy and examine the entire of the pancreatic duct to see any other remnant lesion. But as in this case, the entire pancreatic duct which is visible in the CT scan is hugely dilated. So most likely we'll have to resect it out entirely. So I'll go for a total pancreatectomy, sir.
Directly, without seeing any lesion, the duct dilatation could be the result of a back pressure by a lesion there, and often the ducts get dilated.
Yes.
Would
No,
you
yes,
decide something intraoperatively, or would you directly go ahead with
the intraoperative pancreatoscopy? Pancreatic duct we'll have to examine.
Pancreatoscopy is fine, but how often it is done, and have you seen one being done?
No, sir.
And with such a huge dilatation, you don't really need to see much, because if the ducts are lesser in diameter, that's when the like pancreaticoscopy comes into play, when you want to assess the lesions. Here, the entire pancreas is already atrophic and almost thin rim of tissue remaining around the duct, and everything is clearly seen on your CT scan. So if the ducts are between 1 to 2 centimeters in size, that's when you can actually go in for a pancreaticoscopy and see if something is there as an additional investigation before you proceed with surgery. Otherwise, in such cases, what will you do in intraoperative period to decide whether total pancreatectomy or limited resection of the lesion?
So we can go for a frozen section, intraoperative frozen section, as well as a fluid cytology from the main pancreatic duct.
Not cytology per se. Cytology is generally not done, and
Yes.
on table is also very difficult. But frozen section is a must for all IPMN surgeries. And how do you decide on frozen section about total pancreatectomy versus conservative surgery? What are you looking at margins?
So I'll be looking for if there is a clear margin, means main duct IPMN, whether it's the specimen which I have taken, whether it's entirely in the specimen or not, that I will be looking for, sir.
So you want, yes, sir.
Any dysplasia or any invasive?
Sir, there is no carcinoma in situ or dysplasia.
Yes, sir.
Dysplasia you are likely to have anyway, because IPMN is a disease which has a field effect over entire pancreas. So you are going to see some dysplasia, but there has to be differentiation between a mild dysplasia, moderate dysplasia, and high grade dysplasia on your frozen. So when you have mild dysplasia, definitely do not go ahead with complete removal, because their endocrine function management goes for a toss, and it's very tough to manage, and it's a slow growing process. You can always come back again after 5 years or 10 years if at all there is any future development of lesion in that remnant pancreas. But if you get a moderate dysplasia, it's debatable. Even people say that moderate dysplasias can be solved. High grade dysplasia is a no-brainer, and then you go ahead and remove the entire pancreas that time. So frozen is a must, basically.
So this patient underwent total pancreatectomy because initially also there was an invasive component. He came with oscos and the frozen was positive. Underwent total pancreatectomy, splenectomy. Lymph nodes were also positive. It was T3N1 disease, and even it was extending to rectoperitoneal tissue. This was the specimen. So I think what will be the further treatment plan, and we'll close the cases because I think we have 1 hour we have gone. So Srijan will stop. Any further treatment plan will be this first. Now it is invasive adenocarcinoma. IPMN with invasive component. So it is T3N1. Naveen and Avjit, any further treatment?
Sir, we'll plan for adjuvant chemo in this patient.
So adjuvant treatment is required once it is invasive component carcinoma. You have to treat it, and adjuvant treatment is needed.
Yes.
Srijan, I think we should complete the case discussion. Or we have time?
You have time for one more case, sir. No problem.
I think we can go ahead and discuss.
There is, before we go, there is one comment in the chat box that I would like to ask.
Yeah.
That was regarding a previous case of SPEN. And the question is that if pre-operatively there are liver mets, shall we proceed with resection in SPEN?
I think if there is symptoms are there and jaundice or compression symptoms are there, then I think resection is needed.
Yes, sir. And there remains some role. I think maybe that can be covered when I'm talking on cystic tumors also in the want of time. And there is another question as to patients with diabetes suggesting that she has now endocrine insufficiency also. I can't get this question.
Yeah, this patient was a diabetic.
This patient was a diabetic. Okay, okay. So there was an endocrine
But this
insufficiency.
is not a new development of diabetes. It was
Right,
existing.
Okay.
So this is again a 51-year-old diabetic normotensive jaundice for 10 days with one episode of fever and vomiting 7 days back. No prior history of any pain in abdomen, biliary colic, loss of weight or appetite. ECOG was 0. Pallor was mild pallor. Icterus was there. No supraclavicular lymph nodes. No pedal edema. Parabdominal mild hepatomegaly was there. No other findings. Ultrasound showed GB distended with multiple stones. No ISBRD. But CBD was not seen in the distal part. And there was some suspicious mass lesion in neck or head of pancreas. Naveen, how will you proceed?
Sir, as the suspicious mass in neck and head of pancreas is an incidental finding in a case of chronic cholecystitis or acute cholecystitis, sir. So we'll further evaluate for that mass in the neck and head of pancreas with CECT of the abdomen.
Okay. This is the CT scan films. Avjit, you like to comment on this?
Sir, on the CT scan, the pancreas is visualized well, and there is one mass lesion in the head of the pancreas. It appears to be in communication with the pancreatic duct, and with some enhancement is there. And we can also see although gallbladder GB stones are not visible in the CT in the films, there's a stranding is noted in the fundus region with some amount of fat stranding is there, sir. And rest, no other significant lesion was noted in the visualized portions of the liver or the spleen.
And what is the status of pancreatic duct?
It appears dilated.
Pancreatic duct appears mild dilated, so maybe I'm not sure, sir.
And communication?
It is communicating with the lesion, sir.
And lesion is located head and neck. Or where is the neck? This is just anterior to the vein.
Pardon, sir?
Just anterior to the portal vein and SMV. It is just anterior. Most likely it might be the neck region. So what is your diagnosis now? And
yes, PM.
Jaundice.
Sir, it appears main duct Ipmn and compressing or obstructing the distal CBD, sir.
Okay. So could it be stones also, though coexisting? Because there is some acute cholecystitis changes. No ISBRT is there to suggest there is an obstruction at the lower end CBD. Might be the stone which has passed or which was there. It was only 7 days acute history is there. So both possibilities are there.
Both.
Because the location is such, it might be compressing mildly, otherwise it could be unrelated also. So US would like to do, or in this case, what is the plan? Naveen?
Sir, we have to go for an US in this case, sir. US and cytology.
Good. US will also tell if there is stones are there which was cause of jaundice, that also it will tell. So it will help both the purposes. You can do FNAC, you can look for the CBD stones also, if in the lower CBD is there. So EUS was done. And which shows cystic mass suspicious of Ipmn with periportal note. FNAC from cystic lesion shows benign epithelial cells with mild atypia in the background of mucinous material. And cyst fluid CEA was 187. And CA19 on this is serum CA99 was 3,800. Bilirubin was 3.42. So how will you proceed now?
Sir, as there is a gallbladder wall thickening also, so it may be gallbladder malignancy on the basis of CA19-9. So we'll evaluate for gallbladder also, sir.
But serum bilirubin with raised jaundice, whether CA19 has much of value, with a history of fever and cholangitis, could be cholangitis.
Cholangitis.
And CA19-9 will be raised in even pancreatic malignancies also. It's not specific for gallbladder. So you can't see gallbladder purely based on CA19-9.
Yes.
Isn't it?
On CT scan also, gallbladder appears more of inflammatory. Pericholicystic stranding effect was there. And what with how you will interpret the cyst fluid CE of 187?
Sir, it may be in mucinous cyst adenoma and Ipmn both. So we can't sure ki it's mucinous or Ipmn.
But once the mucin is seen, that is either a Ipmn or mucinous cystic tumor. Mucinous is there. So what will be your plan?
So my plan would be, first of all, as the patient, when presented to me, patient is having an episode of cholecystitis. So I will immediately put the patient on any conservative regimen for the inflammation to subside. And in the meanwhile, I will work up the patient and plan him for a Whipple's procedure for complete resection out of the mass, head of the pancreas.
It was not only cholecystitis, it could be cholangitis also. And cholecystitis is just a part of the biliary inflammation.
Yes.
So you would be conserving, or you would be thinking about draining the system?
So I'll go ahead with a conservative management, as there is no IHBRD. System is not dilated.
It's biliary IHBR, yes, but the bile duct is dilated and bilirubin is, I'm sorry, I just missed that.
Bilirubin was 3.7.
So there is jaundice, which is obstructive jaundice, and patient has shown features of cholangitis, isn't it? There is fever.
Yes,
so cholangitis with obstructive jaundice, would you do conservative management or would you stent them?
So I'll do a stent and drain it, so as the cholangitis can resolve.
Yeah, generally it's drainage, irrespective of the level of bilirubin, because even if bilirubin is lower level like this 3 or 4, in general, for a patient with obstructive jaundice who's planned for surgery, you would not stent them. But the moment there is any cholangitis, there is any hypoalbuminemia or deranged liver function tests in terms of the INR or the liver enzymes, AST, ALT specifically, not the alkaline phosphatase, that is always going to be raised with obstruction. You should always consider stent placement first. But that is one part. Sir is asking you about the management of the overall situation where there is a neck lesion, which is unlikely to be the cause of obstructive jaundice, but there is something which is in the bile duct which is obstructing, probably a stone. You don't know that.
So I'll do a next. I'll do a ERCP. It will be.
US didn't show any stones and all. US didn't show any
US
stones.
did not show any stones. US did not show.
US didn't show any. So no ERCP was needed. And patient had one episode of fever, and after antibiotics, it all subsided.
Sir, it can also be that in a case of Ipmn, be the main duct Ipmn more commonly, the mucin material, the viscid mucin material blocks the system temporarily. So that can account for means it has blocked a CBD temporarily, transiently, and it had caused the jaundice, dilatation of the distal CBD.
One episode of mild pancreatitis, and that could be one explanation. But the pancreatitis evidence was not there on CT scan. More of cholecystitis and all were there. So now everything was settled. Now the surgical plan, what will be your surgical plan?
My surgical plan, sir, will be Whipple's procedure with intraoperative pancreatoscopy to evaluate the rest of the main pancreatic duct, or a frozen section intraoperative.
Pancreatoscopy, which you have not seen, and most of the centers in India don't have a pancreatoscope.
In that case, we'll go ahead with a frozen section intraoperative.
Operative ultrasound, you should say. Frozen section is fine to check neck margin, but to evaluate the rest of the pancreas as an alternative to a pancreaticoscopy is an intraoperative high frequency ultrasound by an expert. Okay, that is required in specific to pancreas. That is required in two situations. One is Ipmn when you are dealing with, and the second one is when you are dealing with a functional pancreatic neuroendocrine tumor. In both these situations, you must have an intraoperative ultrasound as a backup in case if you want to evaluate. Okay.
Yes.
So I think we'll. Can we conclude the case discussion, sir? The moderator and the examiners.
I think this patient underwent Whipple's, but multiple frozen section of distal pancreas also, where two frozen sections were positive. Then it was decided to convert to total pancreatectomy.
Okay.
So I think, Manish, you can conclude if anything extra points you want to mention.
I think, sir, your cases were just superb, fantastic. All the aspects, all the different type, including the images, were really nice. So that we could have a brief and in detail actually discussion on management things. I don't have anything to add to the case slides that we discussed. Maybe anyone else? Shrijan, you would like to add something?
So we would love to hear from you for your expert talk. Now, what we request you and Dr. Shailendra sir would be to rate the performance of the residents today and any tips for them for their coming exam.
Sure, we will do that. I suppose we do that later, right?
Let's do that now, sir, because once we have finished this mock examination. So, Shailendra sir, how did Abhijit and Naveen do, and any tips for them?
I think both have done well. And I think most important thing is they should be able to read the CT scans properly, and they should know how to describe those findings. Those words are important. How the morphology of the lesion is looking like. You should have a thought process how to present your CT scan findings or MR findings, how to systematically everything which are relevant. You should describe all those things. I think you should practice those things, especially whenever you are speaking, then you just have a thought process how to describe those findings.
Thank you, sir. That's an excellent pointer for the residents who are attending. We will hear from Manish sir, both for the residents as well as the expert talk. So I think now we'll just hand over the virtual mic to Dr. Bhandari, and we would love to hear from him.
Just to add to what Shivendra sir said about these students is that when they speak up, the clarity of thought needs to be there. You cannot say one thing and then go back to something else. That doesn't go well in examination. So you can take a pause, you can take a brief while before you start. There is no pressure. You don't have to jump to something whenever the question is asked to you, so that you get that fraction of a second to think that how much I should speak and what exactly I need to go. That works well. It had worked well for me also when I was an examinee that time. So that is one thing. And yes, CT scan reading is important. The topic, the knowledge over the topic is of course important, but it finally comes to how you present yourself and what you say in examination that matters the most. So even if you don't, you're not going to be, as Srizan said in the beginning, you will not be knowing everything. But it's totally fine to say that I have limited knowledge in this area. I would not be able to comment on this in exam, rather than saying something which you just need to say in exam. That doesn't go well. So that is what I would say. And should I start sharing my screen?
Yeah, sure. Dr. Manish, yeah.
Okay, is it visible?
Yes, sir.
Okay. So the brief given to me today is to speak on cystic neoplasms, contemporary management and controversies. Some of the controversies and the evaluation bit we have already covered in the case discussion, and that I would skip in the want of time. And I think I would try and finish the talk between somewhere between 25 to 30 minutes. So because the problem with pancreatic cystic neoplasms now is that they are getting more and more diagnosed, simply because the cross-sectional imaging has become very, very common to even investigate for smallest of the problems. And that's how most these asymptomatic benign appearing pancreatic cystic neoplasms, as well as some of the smaller neuroendocrine tumors which are non-functional, are getting detected in more and more numbers. And when that comes to the clinician, that becomes a real problem, because you don't really know now what to do with these kind of cysts, which are asymptomatic, which are small in size. And there is no large level 1 evidence which is available, which would tell you to act in one way or the other. So that's how we have some guidelines, and the goal for the treatment or the evaluation further in these cases is to primarily assess whether a cyst has a real risk of malignancy, and also when you want to see that whether that cyst is immediately symptomatic or is likely to become symptomatic in near future, and then plan for the management in these cases. So as per WHO and from the other classification, there are various types of cysts that have been classified, but the four important ones cysts that we also saw in the cases is serous cystic neoplasm. I think that's something which we did not see in the case. Mucinous cystic neoplasm, solid pseudopapillary tumor, and the Ipmn, which can be either branch duct or the main duct. These are the main four types of cystic neoplasms, apart from the other less common cysts. So in this talk, we would restrict to management and decisions for these four main cystic neoplasms. Their presentation, as I said, most are asymptomatic because they are incidentally detected. But the symptomatic presentation can also be associated with new onset acute pancreatitis that can happen when the main duct of the pancreas, or even sometimes the branch ducts, are getting occluded or obstructed by these lesions. The long-standing pressure on the, or back pressure on the main duct, can also lead to atrophy of the distal pancreas, and that's how they can have exocrine or endocrine insufficiency, because these are benign tumors. This is especially observed in solid pseudopapillary tumors, where the pancreas, the remnant pancreas, is often seen to be atrophic, even though there is no major pancreatic ductal dilatation. It can happen with spens. Obstructive jaundice, of course, can happen in pancreatic head lesions when there is bile duct obstruction. The guidelines for evaluation, we also had a brief discussion about this during the cases. The first was in 2006, the Sendai guidelines, then the IAP or the Fukuoka guidelines, which was the updated version. There is American Gastroenterology, AGA guidelines, and the recent 2018 European guidelines, which have been revised also, which tells us about the evaluation of a cystic neoplasm and also the management plan, and also gives some knowledge on surveillance of what are the protocols used for surveillance. I would recommend that you all of you read these guidelines because they are heterogeneous, but you will at least get to know what is the basis of these guidelines and how these guidelines propose one or the other way management for the management of the cystic neoplasms. Evaluation bit, as I said, I would skip because to sum it up, basically when you suspect a cystic neoplasm on any ultrasound nowadays are even better with color Doppler imaging and the other features which are available, which can give you detailed information about that particular lesion. But also when the cystic neoplasm is suspected strongly on ultrasound, often the first choice of imaging is a triphasic pancreatic protocol CT scan that will give you a good amount of information about the lesion location, etc., and characteristics also, and also the other factors and the association or the relations to the adjacent structures. MRI is also equally good in assessment. So always there is going to be a question as to whether CT scan first or MRI first, but most of the times one imaging modality is quite useful, either MRI contrast enhanced or a contrast enhanced CT scan. And sometimes when you have doubt, you also need both these investigations because they can act as complementary also. As we also discussed that there are advantages and disadvantages of CT versus MRI at some points in, so maybe you can need two of the imagings also. And when you have a dilemma, even after CT scan or MRI, then comes the role for EUS evaluation, which can also give you the possibility of obtaining a tissue diagnosis. Also, there are certain features on EUS which can directly point towards the one or the other type of a lesion. And then you may also not need any kind of a tissue diagnosis from EUS if you can characteristically see certain these findings on EUS. For example, in mucinous cystic tumors, there can be septations and it's a more homogeneous type of an hypoechoic lesion versus a serous cystic neoplasm, which is often something like a honeycombed appearance or microcystic appearance also. Cyst fluid analysis, again, we saw this. The analysis needs to be sent for CEA levels, CA 19.9 levels, and serum amylase levels. These are the three main things that you need to send them. If the amylase is high, of course, you know that this is either a pseudocyst or it's an Ipmn with the main duct communication. If CA or CA 19.9 is elevated, that confirms either it's an mucinous cystic neoplasm, or sometimes again in Ipmn also these tests may be raised. But you don't have to do EUS for all. Again, this also we discussed. Again, you can read up these guidelines because they have proposed different criterias. But as I said, the European guidelines are the best, which say that if your management is going to be altered, only then order an EUS test. Otherwise, you can let EUS go. Coming to the individual cyst characteristics, yes, there are clinical and distinct radiological features by which you can distinguish these cysts. The serous cystadenomas are generally common in older age group, and they can be located throughout the pancreas without any particular preference as to head or neck or body tail. They are always benign with negligible, or I would say absent risk of malignancy. So there is no risk of malignancy at all in serous cystic neoplasms. When you have doubts on radiology and then you do a EUS evaluation, you would not find any elevated tumor markers. And on CT, you can have either a single cystic lesion, which is clear, or you can have a microcystic lesion, and you can also have a central uh, calcification, a burst type of a calcification with hypervascularity or with honeycomb appearance. So that is characteristic of serous cystadenoma. For mucinous tumors, they are usually homogeneous single cyst, which are most common in middle-aged women. They are often incidentally detected. Again, most commonly, they are not located in the head. In fact, very rarely you will find an MCN which is located in a head. So most often they are going to be in the body tail region only. And on EUS, you will get a high CEA levels and mucinous epithelial cells as well. On CT scan, again, it's a well capsulated, as I said, and you can have an eggshell type of a peripheral calcification within the cyst wall. Thirdly, the solid pseudopapillary tumor, they often grow large and are detected in young women. 90%, more than 90% are young women, but rarely they can also be seen in males as well. They can be located throughout the pancreas with no specific preference. The risk of malignancy is about 15 to 20%. And often you don't need an EUS test when you have a characteristic appearance on imaging, as we also saw in the cases and you see in these images. And these lesions tend to abut portal vein or superior mesenteric vein, and rarely they can invade or also give rise to tumor thrombosis. The fourth cyst, which is the intraductal papillary mucinous neoplasm or Ipmn, again is middle age or older age individuals. It is seen. It can be main duct or branch duct, often incidentally detected, and has the highest risk of malignancy, which is mainly in the main duct IPMNs. The branch duct IPMNs have relatively lower risk of malignancy. Again, EUS tests can be done and the markers will be often found to be elevated in these cases. So generally for mucinous cystic neoplasms and IPMNs, as I said, the CA levels are high, and often the cutoff value for CA, which is taken to be labeled as high, is about 190 or 192 as per various different studies. And nowadays, recently, there is also mutation analysis, which is possible on the cyst fluids as well as from the FNACs, but they have limited roles, which are mainly in IPMN and MCNs, but they are still investigational and they are not still having any impact on management of the cystic neoplasms at this point in time. Coming to the management, as I said, serous cystic neoplasms are often asymptomatic and they tend to grow very, very large. In older individuals, they are detected most often, but they may start very early in age or maybe in the middle age, but because they are asymptomatic, they can continue to grow to a larger size over a period of time until then some symptoms are produced. So generally, as I said, they do not have any risk of malignancy. So the surgery is only indicated when there are symptoms related to compression of the bile duct or stomach, or portal vein is invaded. And when you have an uncertain diagnosis where malignancy is a concern, but you cannot really make out based on your CT, MRI, or even EUS evaluation whether there is any risk of malignancy and this is really a cystic neoplasm, that's when the cysts are going to be operated. And a relative indication is large size, which can vary depending on various studies. Some have said 4 centimeters, some said 6 or 8 centimeters also as a size criteria to offer surgery, but that should be considered as a relative indication, because as we are getting larger and larger multicentric data, most often surgery is not required for these even large type of serous cystic neoplasms, and we can very well let them go and be under observation and act only in presence of symptoms, and that is what it's going to be in near future. So you don't really need surgery unless there is a major symptom coming from a serous cystic neoplasm. For mucinous cystic neoplasms, almost for all, of course, you have the guidelines and cyst size criteria, etc. But for almost all mucinous cystic neoplasm surgeries indicated, because they have a real risk of malignancy and surgery is often curative. Observation is an option, but that should be only in elderly or frail individuals where there is a morbidity of surgery. And you can also have an argument that if the cyst has remained for so long in elderly patients, it is unlikely that it will turn into malignancy. And then you can have observation in only those cases. Otherwise, surgery is a must for all kinds of MCNs. Coming to the solid pen tumors, solid pseudopapillary tumors, most often again they are very, very young age, and they also have a risk of malignancy which is close to 20%. And if not operated, they are definitely going to grow larger in size. And as we discussed, it has a predilection or a tendency to push and also at times invade the portal vein. And when that happens, you really have the risk of metastatic disease development also. So in order to prevent all this, again, for SPEN tumors also, a radical surgery is indicated in almost all cases. Even if the tumors are smaller, you can also do conservative surgeries, but with 1 or 2 or 3 centimeters of size also, you would like to go ahead with surgery. But of course, this is not something which is urgent. You can give time to the family, they can plan it. You can do it after an year or two later also for smaller lesions. But for larger lesions, you need to go in as early as possible, and an aggressive surgical approach is what is warranted in these cases. Often, as I said, these tumors are very, very large at presentation because they are really asymptomatic, and most are undetected early in the phase. We have a large experience at Tata Memorial Hospital. This we had published 3 years back on our 50 cases of pseudopapillary tumors with resection. And with radical surgery, the long-term outcomes are excellent. There is no perioperative problem. And I think recently we have completed about 80-85 cases with SPEN. And what we observe is that median age is very young, which is 24 years. The median tumor size that we see in the referral center that we have at Tata of 7.7 or close to 8 centimeters. Almost about 20% of cases do require some kind of vascular resection, which is mostly a portal vein resection. It almost never infiltrates superior mesenteric artery. Artery is always free, but sheerly because of size or sometimes because of invasion, you may need a portal vein resection. And R0 resection is mostly possible in almost a majority of these cases. And with complete surgery or resection, you hardly get any recurrence. But if it's a margin positive resection, then you are almost 100% sure that you are going to have some kind of a recurrence somewhere or sooner or later. And then that should also prompt you to plan for any aggressive surgery again. Now, aggressive surgery is a norm for SPENs, but that is mainly for larger tumors. But when you have smaller kind of SPENs, or when you have smaller smallest mucinous neoplasms also, organ preservation is definitely an option in these cases. Depending on the size and the location within the pancreas, a different type of an approach can be planned for a conservative surgery, which can be enucleation, which can be a central pancreatectomy, which can be a spleen preserving distal pancreatectomy. As against when we have compared this again, and last year only this got published and came to PubMed. This is 2021, that when you compare the organ preserving resections to a standard resections like Whipple's or a distal pancreatectomy, what we found was the major morbidity is very high, because you have often with median pancreatectomy, you have two cut surfaces of pancreas, so the chances of leak are more. And then you can get major morbidity, which is high in the immediate post-operative period as compared to the standard resection. But when we compare the long-term outcomes, the exocrine and endocrine function is best preserved with conservative surgeries, and that is the main thing that you are looking at these in these benign or low grade malignant tumors, that you need to have a good long term quality of life in terms of both endocrine and exocrine function, and that is why it fares very well. And whenever there is a possibility or an option of organ preserving resection, that should always be offered in such cases. One interesting part that I can also tell you now, that when you have larger tumors, of course, the in the body centrally located, the direct impression or direct plan that you make is to do a radical surgery with distal pancreaticosplenectomy. But if you note here in this particular CT scan, you can see a small tail of a normal pancreas, which is free from any involvement. And when it is less than 5 centimeters of tail remaining, generally it is considered that it's not a suitable case for a central pancreatectomy, and the plan is distal pancreaticosplenectomy. But what we have done in this case and 4 other cases, in so total of 5 cases, that we do a central resection and we leave behind the small tail of pancreas, which may serve as a potential endocrine, which may continue to have a potential endocrine function, and the diabetes risk or the development of diabetes can be delayed in these cases. And you don't even have to do an enteric anastomosis or a pancreaticojejunostomy, because most of the times these are very small size tails with atrophic pancreatic parenchyma in terms of the exocrine function, but the endocrine function may still be intact. Surgical principles, again, I will not go into the details. For large spens, you need a radical approach. For all other lesions, and also for IPMNs with invasive cancers, you need radical approach. But for all other mucinous cystic neoplasms and smaller lesions, a conservative approach is good. Open surgery has been a norm for pancreatic surgery, but as we also have minimal access surgery coming in for even malignancy, for serous cystic tumors, or for cystic neoplasms rather, a robotic or a laparoscopic approach is also very good, because that gives a best cosmetic results, which may be more meaningful in these kind of benign lesions. Robotic approach, I would say, offers or scores better, especially when you want to do something like a central resection as against a distal pancreaticosplenectomy, which is also equally well possible with laparoscopic approach. But some centrally located lesions such as this, when you are planning a central resection, of course, the advantage with robot comes in for dissection of the pancreatic parenchyma from the underlying splenic artery and splenic vein, which can be tedious with laparoscopic approach, but is of course possible. And secondly, the division of pancreas and then future pancreatic anastomosis, which is definitely much better with robotic approach when we do a central pancreatectomy. So you achieve a margin negative resection. You don't need a large margin, and then prepare a roux limb of jejunum, which is inserted in the supracolic compartment from the transmesocolic route, and then a pancreaticojejunostomy is performed. Coming to solid pseudopapillary tumor surgery, these are often large, as I said, and they can have venous involvement. And this is one such case where the head tumor is large and it has involved portal vein, or there is a tumor thrombus that is seen in the portal vein. Now, again, there was also a question about metastatic disease. Yes, when this happens, you can have multiple liver metastasis also. When there are smaller or less number of metastases, of course, there is no doubt, then there is no problem. You can remove 1 or 2 isolated surface liver mets. Most often, the liver mets in SPEN are not large in size. They are often 1 or 2 centimeters, or at the max 3 centimeters. And even if you have more than 5, 6, 10, 15, the largest we have removed is, I think, 19 liver metastases by individually coring them out from liver. And that is absolutely justifiable and absolutely worthwhile, because the patients tend to do very well in long run. Also the case with portal vein involvement, that should not be a criteria that to preclude any resection. You can do a definitely safe resection, and sometimes you find this kind of a tumor thrombus which is attached to the vein wall, which can be removed by clamping the vein, taking control, and then removing the thrombus as well. Now for managing the main duct IPMN, it's commonly observed in elderly men's, and yes, it can be main duct and branch duct, and also you can have a third type which is mixed, when you have main plus the branch duct IPMN. Uh, what we need to know, and this is what is updated in the recent guidelines also, is that you need to find out the certain worrisome features or some high risk stigmata in these cysts, which would prompt you towards the risk of malignancy in that individual case, so that you can risk stratify these cases better. So if there is MPD diameter which is between 5 to 9 millimeters, if there are enhancing mural nodules, if the cysts are more than 3 centimeters, any lymphadenopathy, any abrupt change in the MPD diameter, elevated serum CA19-9 levels, and a rapid cyst growth should prompt towards a investigation immediately. And when you have any obstructive jaundice and the mural nodules are more than 5 millimeters and the MPD size is more than 1 centimeter, it is considered as a high risk stigmata for harboring any kind of a malignancy, and an urgent surgical referral is expected from the treating physician or from the gastroenterologist. So this all we discussed, that frozen section is a key for when you are managing the IPMNs during surgery. You can have low grade dysplasias, you can have moderate dysplasias, and the indications of total pancreatectomy, this we discussed in the case. Now coming to branch duct IPMNs, yes, the management approach is really evolving in this particular field. I think we have enough data and evidence for all other types of cysts as regards their management. But for branch duct IPMNs, there is still a lot of consensus and drive which is recently coming in for more and more conservative approach, as we know the natural history of these kind of tumors, which are known to be different from any kind of a main duct IPMN. So more and more guidelines have been now conservative. We discussed about the 3 centimeter criteria in one of the cases, but that has been increasing now. They are doing it 4 centimeters or 5 centimeters, and also then wanting to analyze these cysts more by doing endoscopies, ultrasounds, and also taking out fluid for diagnosis, and also performing molecular markers in those particular cases, and then decide whether this particular cyst can be observed versus versus operated. So absolute indications are definitely presence of any obstructive jaundice or a cytology which is positive, or you have larger size mural nodules. But all other criterias, including the size criterias, are relative indications, and more focus is towards observation. Again, for the want of time, I would be running through a little quickly. IPMN surgery has to be radical again, including lymphadenectomy. And we also saw that adjuvant treatment is required in these cases when you have any kind of an invasive component. So coming to surveillance, surveillance is recommended differently by different guidelines again, but the brief is that you would keep a cyst, keep only a serous cystadenoma or a branch duct IPMN under observation. For all practical purposes, any other cyst, be it mucinous tumor, be it solid pseudopapillary or a main duct IPMN, it will definitely undergo surgical resection sooner or later. And sooner is always going to be better, because either the patients are younger in age and they want to proceed in their studies, life, career, marriage, etc. So sooner the surgery is done is better for them. And also for middle or older age patients, when they are most fit in their life, that is when the surgery should be planned, because otherwise with increasing age, it is also going to be difficult. So the surveillance criteria for the branch duct IPMNs is defined well, that you have to do them frequently, more frequently in the initial time period, which can be yearly in the first few years with MRI and MRCP most of the times, because of less radiation exposure, and slowly the duration can be increased in terms of the follow-up as well. In terms of surveillance after resection, this also we discussed. Surgically resected mucinous tumors do not really require, with radical surgery, with margin negative resection, do not really require any surveillance. Uh, uh, those who have been resected and have had an invasive component which can have a risk of recurrence should be followed up, which is in a similar fashion to you as you follow any other case with pancreatic ductal adenocarcinomas. For IPMNs, if you have done a partial pancreatectomy, then the patient needs to be under lifelong surveillance, because the risk of recurrence in the remnant is high. And if the patients are not willing to undergo further follow-up or is unlikely to be fit, that is also a relative indication to do a completion or a total pancreatectomy right at the index surgery also. Similarly, IPMNs with high-grade dysplasia or low-grade dysplasia are also having a different kind of surveillance pattern which is advocated. So coming to the end of my talk, what we really need to know in future about cystic tumors and what is really required is to have a large multicentric international, possibly international studies, where we need to refine the management plan for mainly the branch duct IPMNs, because as I said, we have the answer for all other cysts as to what we need to do, but mainly for branch duct IPMNs and also for certain smaller main duct IPMNs also, there could be a possibility of observation, and unless and until we get some concrete data and to the molecular markers, all these cysts are likely to undergo resection. And we have had one small step towards a multicentric study, which was led by Tata Hospital by my colleague Vikram Chaudhary, where we saw the Indian picture of cystic neoplasms and how they are treated. It was not a big paper or a very informative paper, but it was like an audit of what is really happening in terms of management. And what we found was that the evaluations itself are so irregular, and so often we have found that incidentally a cyst is detected thinking that it was a malignancy. So that is something which can be refined. And at Tata, we have an experience of about 160 odd cases of cystic neoplasms which have been operated. The standard resections have been performed in most of the cases as compared to organ preserving resections. I would say about 75% of the resections are standard or radical resections, either pancreaticoduodenectomy or distal pancreaticosplenectomy, mainly because, as I showed you, the median size as presentation is very large. And that's how the organ preserving surgeries are only possible in smaller tumors and anatomically favorable locations. Yes, we can have open surgery, which is the major workforce, but also minimal access, laparoscopic or robotic approach is also fine, but you need to select out your cases well. And the morbidity is good. And unfortunately, there was one mortality in a case of IPMN, but rest have all done well. So if we have to tell you about a algorithm as to how to manage cystic neoplasms, yes, initial investigation is a CT scan or MRI scan, and then you need to know whether the cyst is symptomatic or no. Symptomatic cyst, there is no discussion, there is no big thought process. Yes, there is dilated pancreatic duct, there are mural nodules, there is main duct involvement, operation or surgery is a direct indication. But when you have an asymptomatic cyst and the pancreatic duct is not dilated and there is no radiological feature of malignancy, then you can go by the size criteria also, whether it's 3 centimeters, more than 3 or less than 3. All such kinds with less than 3 centimeters, you can safely observe them by not asking any additional investigation also. Of course, you would also do an MRI scan if you have done a CT scan in the beginning, so that you have two imagings when you know any communication with duct. But if the cyst size is smaller than 3 centimeters, if there are no symptoms, and if the main pancreatic duct is not dilated, safely you can observe, because most often these are serous tumors or branch duct IPMNs. When the size is more than 3 centimeters, then you really need to assess how much is the risk of surgery. That is, if the patient is young, old, comorbidities, etc. And if you have a low risk of surgery, then do not subject the patient to additional investigations and go ahead with surgery safely early. And if you have a high risk of surgery or an elderly patient, then you of course do all the other possible tests to justify a surgery for this kind of a cyst, and then only go ahead with surgery in these cases. When you have negative outputs of the EUS or ERCP in these larger tumors, but there may be minor symptoms, but surgery is still a high risk, then you can have options of observation or ablation of the cyst, but they should be kept to minimum. Those are very, very few and rare indications. So to conclude, I would say that the cysts can have heterogeneous presentation, and they have a heterogeneous group of lesions, all 4 lesions that we discussed. You often need to have a involvement with your radiologist, with your gastroenterologist to properly evaluate a cyst, and have a multidisciplinary clinic discussion as to ascertain a real risk of malignancy. And you can only then you can have an optimum plan for your individual cystic neoplasm. So I thank all of you for listening, and I thank IASO and Dr. Subramanyeshwar Rao and Dr. Shrijan for inviting me for this lecture. Thank you.
Thank you so much, Dr. Manish Bhandari, sir. That was indeed a very well dissected talk on a very vast and heterogeneous topic, and almost a compendium for the residents who can revisit this on YouTube. And maybe these 25-30 minutes were not enough to get all this data in, and they can do this in steps again. This brings us to our last segment, and we don't really have too many questions left because they were all so well covered in the first 2 segments. So the only 3 questions that I have here from the chat here on YouTube, I'm forwarding these questions to specific examiners, but obviously the others are also welcome to contribute. The first question is pancreatic enzyme replacement, in whom to consider, when to start, and how much. How do you decide on all that? Shivendra Singh, sir.
Usually we don't give a replacement to all the patient unless the patient has steatorrhea, clinical steatorrhea, and only then we give enzyme supplements. Or if we are doing a pancreaticogastrostomy or pancreaticojejunostomy, and all, otherwise we don't give replacements in all the patients.
Yeah. Manish, sir, anything you want to add?
For standard Whipple resections, we also give PERT for the initial 3 months, because sometimes even if we have a practice of doing a pancreaticojejunostomy only, which I would say would have lesser risk than a pancreaticogastrostomy, but still initial period of time, sometimes the enzymes are on lower side and they need some kind of a supplement. But otherwise, as Dr. Shivendra said, only in symptomatic patients, and after at times confirming on fecal elastase level, then we add the enzyme replacement.
Right, sure. Our second question is OPSI prophylaxis. When and how do you plan it? Manish, sir.
So it's at least given a week prior, the prophylaxis, the triple vaccine that we give, the influenza vaccine, the Hep B vaccine, and the meningococcal vaccine. These are the three things that need to be given. And in a planned case, yes, it is ideal that it is given at least 7 days prior to surgery. You can give before that as well, but minimum of 7 days gap has to be there from surgery. And if for some reasons this has been missed, then do not give it within that 7 days span. Let the surgery happen, and then post surgery after about 2 weeks or so, you can give this prophylaxis at that time. And then also importantly, these patients have to be instructed that this is not a one-time prophylaxis, and they have to repeat the doses after each 5 years.
Right. Shivendra sir, any differences, or should we go to the next one?
No, actually, our experience from our GIs for shunt and splenectomy for portal hypertension, we have not been using or any prophylaxis for OPSI. We have never seen any OPSI in our experience. So,
no.
But guidelines says that you should be using, but Indian data for portal hypertension and shunt, none of the patients received in all the major centers, and we have never seen any OPSI.
Okay. Thank you, sir. The last question for today is on post-operative management, drains, NG tubes, FJs, and post-op diet, the approach of experts. So I think we'll hear from Shivendra sir and then Manish sir on their approaches.
For Whipples, we usually place Whipples or any pancreatic cells, we place drains. And feeding gesnostomy in all Whipples, we either put our feeding gesnostomy. NGT we always keep, but we'll take out by day 3 in Whipples. And for distal pancreatectomy, we'll take out in the first day, day 1, we take it out. And post-op diet approach, as such, is only we start with liquid diet, and the soft diet we start by the 4th day for Whipples. Another for 3rd day 3 or day 4 we start soft diet, and no special restrictions except for we are careful for watching for diabetes. We keep a watch for regular monitoring, and rest no other specific diets.
Manish sir.
Yeah, what I would say is drains, yes, always 2 drains for Whipple and 1 drain for distal pancreatectomy. For median also 2 drains, and these drains are soft drains and the flat drains, the Jackson and Pratt GP drains that we call it, not the regular tube drains. Somehow we have found them better to place and better cosmetically also and functionally also better for patients. But tube drains are also good enough. Feeding jejunostomy, we do not do it routinely, but we place a nasojejunal tube selectively in cases who are elderly, who are diabetic, or who have a high risk pancreas to be anastomosed, where the risk of leak is high and the risk of secondary DGE or delayed gastric emptying is high. Selectively a nasojejunal tube, otherwise no feeding tube in the form of NJ or FJ. Nasogastric tubes, yes, we retain them till first day, and depending on how the output has been, by 2nd or 3rd day it is removed, as Dr. Shivendra also said. And for diet, we have an ongoing ERAS program, so we encourage diet as early as the patient wants, but it's not something which is strict. We always ask the patient, and if they are feeling hungry or feeling like having something by mouth, if they are okay to have it by 2nd day, yes, we allow soft diet also. But at times they are not okay to have it, and then for first 3-4 days they will continue to take liquid diet by mouth. And if the DGE develops, then we of course use the nasojejunal tube. Otherwise the nasojejunal tube is just for the backup in the event of DG, so that in the post-op the patient doesn't have to go in for any other intervention for placing a nasojejunal tube, etc.
Thank you, Dr. Shivendra Singh and Dr. Manish Bhandari, for so calmly answering all these questions now, and being so patient with the residents initially, and then answering the chats, the questions on the chats as well. I really thank you for this wonderful webinar, and I'm sure that many other residents who are not able to attend this live will be benefiting it by viewing it on YouTube later. I invite IASO past president, Dr. BKC Mohan Prasad sir, to deliver the vote of thanks for today's webinar. Sir.
Good evening, everybody. I'm really thankful for the opportunity to say the vote of thanks on behalf of the IASO academics. I really enjoyed the discussions on the cystic neoplasms of the pancreas, and especially by Dr. Shivendra Singh and Dr. Manish Bhandari, who covered almost all the points in the management of cystic neoplasms of the pancreas. I think which will be very, very useful for the GI oncosurgeons for their for carrying out their practice as well as to treat their patients. I also thank the IASO academics, mainly Dr. Subramanian, my good friend, and all the oncosurgeons at the Vasavatharagam Indo-American Cancer Center for doing the excellent job on behalf of the IASO academics. I take this opportunity to invite you all for the NetCon IASO 2022, which is going to be held in Madurai this year. And we are going to workshop on the 6th of October, and the main conference are 7th, 8th, and 9th. And October, it is going to be held in Hotel Marriott at Madurai. And we have planned very many good international and national participants, both for the workshop and for the keynote lectures and the debates, panel discussions, and oration, etc. And Madurai has got a good connectivity today from almost all the cities in the country. And I definitely assure that it will be definitely an academic extravaganza. And I think some of you might have attended the IASO NatCon in 2005, held in Kodaikanal. And our hospitality will still more increase this time. And I will be happy to have all of you, including your surgical onco friends, other members of the IASO, to come and participate in the NatCon IASO 2022 in this October and make it a grand success. Thank you very much.
Thank you, sir. We thank you all for attending the webinar tonight. We'll conclude this meeting here. Stay safe, everyone. Good night. The next meeting would be the mediastinal tumors on 30th June, same time, 7 p.m. on Thursday. Thank you so much.
Thank you.
Thank you.